Good morning. Welcome to this morning's hearing, Preventing Harm, Protecting Health, Reforming CDC's Environmental Public Health Practices. This is the third subcommittee hearing to examine the performance of the Agency for Toxic Substances and Disease Registry, ATSDR. Today we will expand our work to examine the work of its sister agency, the National Center for Environmental Health, NCEH. Together those offices are the Centers for Disease Control's experts in performing environmental health evaluations. In previous hearings, we documented problems with ATSDR's work on formaldehyde and the safety of trailers provided to families that survived Hurricane Katrina. We also documented problems with ATSDR's environmental assessments at Camp Lejeune, Vieques, Puerto Rico, and Midlothian, Texas. 3 of the 4 cases mentioned have seen health evaluations withdrawn by ATSDR, and the 4th is under review. They are to be commended. We do commend ATSDR for their willingness to admit failings, but today we will hear reasons to worry about what they're doing to make sure there are not failings in the future. We will examine one of the past examples, looking into current actions via the CDC to launch a new public health evaluation at Vieques, Puerto Rico. Additionally, we are releasing a staff report that documents serious flaws in an article written by CDC staff in 2004 to respond to the district's lead in water crisis. That article, the District of Columbia, that article was built on significantly incomplete data for one of the 2 studies and unreliable data in the other study. But the message to the district residents in the article was very clear. No serious harm resulted from the elevated level of lead in their water. After that article was published in the Morbidity and Mortality Weekly Report, the MMWR, in March 2004, the public clamor went away, press coverage died down, and most of the federal staff dispatched to assist the city validated the message that there was no crisis by quietly returning to their home agencies. The authors knew that there were problems with those studies, but in their disclosure of the limits of their data, they did not say a word about missing data or confounding variables. This subcommittee cannot possibly identify every mistaken evaluation, assessment, report, or article done by ATSDR or NCEH staff. That is not the role of congressional oversight. We do not do peer review. We are not peers. But the CDC must take the steps themselves to make sure that these offices get on the right path and proceed in a way that avoids those problems in the future. And sometimes to get on the right path, you have to determine what constitutes the right path and what constitutes the wrong path. Our previous hearings and today's testimony makes it clear that the wrong path includes, or has included in the past, conducting studies designed to make it impossible to find a health problem. It is not the role of the government to tell everybody that they've got nothing to worry about. Analyzing data that is incomplete, inaccurate, or irrelevant to the underlying question without disclosing the known limits of the data. Responding to critics by attacking their knowledge or their motives. Failing to have rigorous and consistent reviews of study design, data collection and quality, analytical methods and conclusions, failing to have consistent policies and procedures for conducting public health research and interventions for publications. All of this needs to change if ATSDR and NCEH are to succeed. We need more honesty and transparency and less attitude. When you work at a public health science agency, and the words that are frequently used to describe your work are haphazard, hit or miss, ad hoc, maybe you should pause and reflect. This morning we have a new analysis that reworks part of the MMWR article on lead in D.C.'s drinking water with more complete data on blood lead tests for district residents. The NCEH staff had more complete data, but they manipulated it, scrubbed it in a way that can't be evaluated by experts or by the public. They provide no real levels, no real numbers of children with elevated blood levels, something that residents would understand, and it makes it impossible to compare their raw numbers to numbers reported by the district or this subcommittee. Most important, the other years in this longitudinal study were treated in a different way that makes it almost impossible to compare, undermining the validity of the entire exercise. Undoubtedly, much of ATSDR's and NCEH's problem is a failure to communicate, in the words of Cool Hand Luke. But we have heard a great deal of evidence that the quality of the science is simply not consistently what it should be. I congratulate Dr. Frieden for initiating a search for a new leader of ATSDR NCEH. A new team can do much to restore the confidence of the staff, to provide guidance about quality and procedures, processes, and give this country a function we desperately need, a reliable expert evaluation of environmental health dangers. There are many talented, committed professionals at the ATSDR and NCEH. Our criticism of the agencies has never been a criticism of the professionalism or the commitment of their employees. 80% of the staff at ATSDR would like to have their work subject to peer review more often. That is obvious evidence that the staff is committed to their job and want to do the right thing. And the public and the employees of ATSDR deserve leadership that matches their own commitment. With that, I now recognize, hold on, now that I'm, yes, I am attaching to my opening statement a report by the majority staff regarding the CDC's response to the lead and water crisis in Washington, D.C. Back in 2004, and also attaching a statement submitted by the Honorable Pedro Pierre Luisa, the delegate from Puerto Rico. Documents for the record. And other documents for the record. Without objection, I now recognize Dr. Brown for his opening statement.
Thank you, Mr. Chairman. Good morning. I want to welcome our witnesses here today and thank the Chairman for holding this hearing. As a legislator and as a physician, I'm certainly concerned about environmental public health. As the Chairman noted, the Agency for Toxic Substances and Disease Registry and the Centers for Disease Control are no strangers to this committee. The subcommittee's previous inquiry into the health consultation report for FEMA regarding formaldehyde in trailers and the agency's work regarding toxic releases in the Great Lakes region pointed to weaknesses in ATSDR's scientific review process, as well as how they convey information to the public. Because of these concerns, ATSDR initiated several internal reviews of those efforts, and the committee asked GAO to review the agency's processes. Additionally, this committee held another hearing to hear from communities about their experiences with ATSDR and spent over a year examining how the CDC and the D.C. Department of Health responded to the D.C. lead crisis. Throughout these processes, it became abundantly clear that the processes by which scientific products are tasked, developed, reviewed, distributed, and communicated are woefully inadequate. GAO's report offers a number of recommendations, but it will take a concerted and a sustained effort to bring about the cultural change needed to ensure public trust. While the work that the agency does is critically important, it is also very difficult. Determining causation and making health determinations is not always black and white. Despite the complexity of their work, the public deserves to have an agency that they trust. And I hope this hearing will help us shed light not only on how the agency can better protect public health and safety, but also how it can adapt to its evolving mission and the appropriateness of this evolution. Additionally, I hope the witnesses can help us understand how the agency can better coordinate with community organizations, other executive branch agencies, and state and local health departments, aside from ensuring that science is always at the center of the agency's work. Understanding expectations and effectively communicating with the public is key to making sure that ATSDR is an effective agency in the future. In closing, I want to thank our witnesses for appearing here today, as well as all the hardworking folks at ATSDR. Thank you, Mr. Chairman, and I yield back the balance of my time.
Thank you, Dr. Brown. We will include any other opening statements from any members in the record. It is now my pleasure to introduce our witnesses today. Ms. Cynthia Bascetta is currently the Director of Public Health and Medical Services at the Government Accountability Office, GAO. While at GAO, she has investigated the federal response to Hurricane Katrina and the delivery of federal health services to responders affected by the terrorist attack on the World Trade Center buildings. She holds a master's in public health from the University of Michigan. Mr. Stephen Lester is Science Director for the Center for Health, Environment, and Justice, NHEJ. Mr. Lester has a master's degree in toxicology from the Harvard University School of Public Health and a master's degree in environmental health from the New York University's Institute of Environmental Medicine. He has worked for 20 years to help initiate reforms at ATSDR. Dr. John Wargo is Professor of Risk Analysis, Environmental Policy, and Political Science at Yale. It says Yale University. He is the author of several books on toxic contamination and the impact on children, and he has served as an advisor on child health-related issues to the White House, EPA, and CDC. He has spent the last 7 years investigating toxic contamination on the Puerto Rican island of Vieques and will discuss his assessment of the CDC's failures to evaluate fully the potential human health hazards there. Dr. Marc Edwards is currently the Charles Lunsford Professor of Civil Engineering at Virginia Tech. He holds an undergraduate degree in basic medical sciences and a PhD in environmental engineering. In 2007, he won a MacArthur Fellowship, commonly called a Genius Grant, and he recently won the 2010 Praxis Award in Professional Ethics from Villanova University. His paper on the CDC lead and water crisis, published last year in the journal Environmental Science and Technology, was selected as the journal's best paper in the category of science, beating out nearly 1,500 other papers. We look forward to hearing from him and from all the witnesses today. As our witnesses should know, you will each have 5 minutes for your spoken testimony. Your written testimony will be included in its entirety in the record of the hearing. When you have completed your spoken testimony, we'll begin with questions. Each member will have 5 minutes to question the panel. It is the practice of the subcommittee, because we're an investigations and oversight subcommittee, to receive our testimony under oath. Do any of you have any objection to taking an oath? Okay, the record should reflect that all the witnesses nodded in the negative, that they did not have an objection. You also have the right to be represented by counsel. Do any of you have counsel with you today? The record should reflect that all the witnesses nodded in the negative, that they do not have counsel today. Please stand and raise your right hand. Well, first, do any of you, yes, please stand and raise your right hand. Do you swear to tell the truth and nothing but the truth? Okay. And the record should reflect that all of the witnesses have taken the oath. And now that you are at ease, we will start with Ms. Cynthia Bascetta. I want to thank you and the GAO for the hard work you have done in response to our subcommittee's request for help with this, and your work was certainly thorough and diligent. You're recognized for 5 minutes.
Mr. Chairman and members of the subcommittee, thank you very much for inviting me to testify today about the need for ATSDR to strengthen its policies and procedures for preparing public health products. My remarks will highlight the findings of our report to the subcommittee. As you're well aware, concerns about the quality of ATSDR's public health products are long-standing. Prior GAO work, other studies, and investigative reports by your own staff document products that have had serious scientific weaknesses. Our findings focus on the organizational climate that contributed to publication of these products rather than an assessment of the products themselves. To do our review, we use the standards for internal control in the federal government to assess the agency's policies and procedures for the 3 phases of product preparation. These are initiating new work, developing the product, and reviewing and clearing the product for publication. For all phases, we documented the lack of some critical controls needed to provide a reasonable assurance of product quality. The first deficiencies we found were during the initiation of new work. ATSDR's policies and procedures establish neither an adequate assessment of risk nor a clear information flow. The agency previously incorporated some of the principles of risk assessment when it classified some hazardous chemical sites as high priority or focus sites, and it required products for these sites to undergo a higher level of review and clearance. It no longer does this, and instead generally relies on various meetings held at different levels to inform management and staff about newly initiated work. As a result, it cannot ensure that it is managing public health products commensurate with their risks. For the product development phase, we found that ATSDR's policies and procedures neither clearly define management roles and responsibilities, nor require that management monitor the development of key components of public health products, such as exposure assessments and health effects evaluations. One official told us that the agency identified staff with the right expertise for assignments. However, we noted in our report that this is not a substitute for ongoing monitoring. Without monitoring, problems that occur during product development may not be identified until review and clearance, if they're identified at all. This can undercut public confidence as well as waste valuable time and resources. Finally, review and clearance policies do not reflect current practices. For example, the review of products in the Division of Health Assessments and Consultation usually stops with division branch chiefs, even though policy highly recommends clearance by the division director or the associate division director for science. Moreover, these policies and procedures direct management and staff to use discretion to identify products that should undergo higher levels of review, rather than determining this through a comprehensive risk assessment process. The agency's criteria for discretionary review include situations in which a document could have a high degree of visibility or contains highly sensitive information. However, because there is no consistent process, ATSDR, again, cannot ensure that its products receive the appropriate level of review and clearance. Mr. Chairman, ATSDR has told us that factors such as scientific uncertainty and resource limitations affect its ability to conduct its mission. We believe that such challenges are precisely why the agency must be held accountable for strengthening its processes to improve product quality. In its current state, management has limited its own ability to monitor agency work and ensure that resources are being allocated appropriately. The Office of the Director is in a reactive rather than a leadership position with respect to the divisions and the public health work it manages. In our report, we recommend ways for ATSDR to provide reasonable assurance of the quality of its public health products. This concludes my remarks, and I'd be happy to answer your questions.
Thank you, Ms. Bascetta. Next is Mr. Lester for 5 minutes.
Mr. Chairman, distinguished members of the subcommittee, thank you for this opportunity to testify on the policies and procedures used by the Agency for Toxic Substances and Disease Registry to evaluate health problems in communities. My name is Stephen Lester. I'm the Science Director with the Center for Health, Environment, and Justice. CHEJ is a national environmental health organization founded in 1981 by Love Canal community leader Lois Gibbs. I joined CHEJ in 1983, and as Science Director, I have easily reviewed many hundreds of health studies, health assessments, and health investigations, including many conducted by ATSDR. It is with this background and experience I offer this testimony. I would like to begin by stating that under no circumstances should the responsibility for evaluating health problems in communities be taken away from ATSDR. It is critically important that a federal agency be available to respond to concerns and questions raised by community organizations. While ATSDR has not done this well, the solution is not to throw the baby out with the bathwater, but to fix the problem and reform the agency so it does its work well. CHEJ spent several years from 1990 to 1992 working closely with ATSDR to help reform the agency. We took on this task following a meeting with Barry Johnson, then the director of the agency. At the time, ATSDR was feeling a great deal of pressure as the U.S. General Accounting Office at the time had begun an investigation into the quality and effectiveness of its work. Our organization sponsors 2 meetings with ATSDR, the details of which are described in my written testimony. I would summarize this experience by saying that ATSDR learned what people wanted and adopted their language in its literature, but the agency did not change what they had always been doing, using inadequate or inappropriate methods to assess health problems in communities. Now, 20 years later, little has changed. CHEJ had a similar meeting in January of 2009 with Dr. Howard Frumpkin, then director of the ATSDR. Dr. Frumpkin came to our office to seek CHEJ's participation in a national conversation that would, among other issues, seek to improve the effectiveness of the ATSDR in addressing health problems in communities. We shared with Dr. Frumpkin our previous experience with the agency and suggested that he begin by looking back at the recommendations that came out of our earlier work. Those recommendations were never acted on and are still applicable today. If the agency had implemented these recommendations, it's very likely there would be no need for a hearing today. ATSDR's inadequate or flawed health studies, health assessments, and health investigations have had a significant impact on communities because decisions are made as a result of these studies that affect people's lives and well-being. These decisions might include whether to require additional cleanup, provide supplemental drinking water, relocate people, or take other steps to reduce exposures. None of these or similar actions are taken when ATSDR's studies find nothing or are inconclusive. Such conclusions might be appropriate if the study design were capable of providing a reasonably accurate evaluation of the potential health problems in a study population. Unfortunately, this is not usually the case. Instead, studies conducted by ATSDR consistently ask the wrong questions, use inappropriate comparison groups, are based on incomplete or inadequate information, and use other ill-conceived scientific methods that lead to irrelevant or inconclusive results. Consequently, people who live in contaminated communities are not getting the information and assistance or the medical treatment they need to protect themselves and their children from chemical exposures. It is difficult to say why ATSDR has acted as it has over a period of more than 20 years. I do feel, however, that much of their behavior can be traced to a lack of respect and interest in listening to and working with impacted communities. ATSDR should seek community involvement and consider the community its partner in developing whatever work is done. I also believe that the agency has been strapped by legislative language that frames its work and restricts its responsibilities and authority. To address some of these problems, I offer a few recommendations. First, ATSDR needs to meet with and include the community early on before it decides how to respond to the questions and concerns raised by the community. How it responds should be tailored to address these concerns and questions. Second, ATSDR should be given the legal authority to provide financial resources to communities so they can participate as partners in the design and development of the studies and assessments they do. Perhaps a health assessment grant, similar to EPA's technical assistance grant, could be made available to each community. Third, ATSDR needs to acknowledge that the scientific methods and procedures currently used to respond to questions and concerns about increased health problems in a community are limited and rarely can provide accurate and useful information about these health problems. Researchers needed to critique the scientific methods and procedures currently used. And lastly, ATSDR should be given the authority it needs to achieve its mission to take appropriate actions to avoid and end public health exposures. I have additional recommendations that are included in my written testimony. Thank you for your time and the opportunity for these comments. I'd be happy to answer questions.
Thank you, Mr. Lester. Dr. Wargo for 5 minutes.
Mr. Chairman and distinguished members of the committee, thank you very much for inviting me. I feel honored to be here today, and I want to share my thoughts with you about the island of Yale case, but also the effectiveness of the ATSDR and CDC in providing their public health assessments. I'd also like to conclude with some recommendations, some directed to reform the science and the quality of analysis done at ATSDR, but also to suggest several legislative initiatives that I think are also necessary. So my name is John Wargo, and I've spent 7 years conducting research on the island, and my research is more fully presented in 4 chapters in a book just published by Yale Press called Green Intelligence. The ATSDR concluded in 2003 that contaminants released by the U.S. and allied forces during the latter half of the 20th century posed no significant health threat to those who live on or formerly lived on the island of Yaquis, Puerto Rico. My own conclusions, recognizing that more than 100 million pounds of munitions have been released on that island over a period of nearly 60 years, including nearly 200 different types of munitions, have created a toxic soup, a mess that I've never seen anything similar to in my experience. My conclusions are that the ATSDR's public health assessments, one on fish and shellfish, another on air, another on soils, and another on water, contain serious flaws in scientific methods, analyses, and interpretations of evidence. Yet the agency consistently concluded that human health risks are not significant. In brief, the agency concluded that the absence of evidence of contamination is sufficient to conclude that the absence of significant health effects occurred on the island. However, the poor quality of environmental monitoring and surveillance make it impossible to justify the sweeping declarations of safety that are made by the ATSDR. One problem with the agency is that it rarely has conducted its own research on environmental contamination, human exposure, disease prevalence, and these flaws are carried through to their analyses and conclusions. For example, the ATSDR on Vieques has conducted no human tissue testing, so they have no firm evidence of what exposures may have occurred and whether or not the body burdens of Viequense still show evidence of the exposures. Finally, I'd like to suggest that the agency's public health assessments are not peer-reviewed. And I would also argue, from my analyses, that they would not stand up to peer review. They would not be published in high-quality scientific journals. Congressman Miller asked me several questions, and I wanted to make a couple of comments about the ATSDR's Fresh Look effort. I had the opportunity to go to CDC's headquarters and to review with them their progress and interpretations of data last fall, roughly 6 years following the release of their public health assessments. I believe that the ATSDR scientists and administrators realized that their 2003 public health assessments and conclusions of safety were premature and poorly supported by available evidence. Is this really a fresh look? Well, I'm not clear about that, and I think that we need to hear directly from them about it. It is certain to me that they are analyzing other data that is now available to them, but they are still not collecting human tissue data. They are still not trying to reconstruct human exposure to the chemicals that were released on the island. They've not conducted their own independent testing of plants, chemicals in plants, or in fish or in wildlife that can become components of the Viequense's food supply. I believe there's an underlying cultural problem here that was alluded to earlier. The ATSDR, I think, has misperceived its intended mission. The public health assessments demonstrate the agency believes that its purpose is to search for conclusive evidence that hazardous chemicals have caused health loss. And since the data necessary to demonstrate and to prove health loss associated with chemical exposures is rarely sufficient, the agency almost always concludes no significant threat to human health, and it declares safety. Yet these conclusions are illogical and scientifically flawed. ATSDR may not have sufficient evidence to conclude community danger, but it similarly does not have sufficient evidence to conclude safety. So I'd like to conclude just by referring to certain principles that might help to reform the agency's efforts. One is they need to track the sources of contamination on the island. There's still no good accounting for what the Navy released, when they released it, and where they released it. This makes the scientific process of understanding human exposure and health risks just about impossible. The agency really does need to do human tissue testing. It needs to study disease prevalence. We need fundamental epidemiology on the island to be able to distinguish health outcomes that the population experienced and try to relate those to intensities of exposure. They need to express their findings and critique their data with analyses of the certainty and quality of each component of a risk assessment, and they do not do that. So in conclusion, I'd just like to suggest that the central problem seems to be their predisposition, their need to prove danger, and I suggest that the standard be reversed. The burden of proof should be on the agency to demonstrate a reasonable certainty of no harm. Now that phrase is taken from the Food Quality Protection Act. Switch the burden of proof on the agency to demonstrate safety, reasonable certainty of no harm. If they needed to do that, I think we'd get a much more thorough evaluation of the data, a much more realistic assessment of patterns of exposure and ultimate health effects. And I'm going to close with one thought. I went back this morning and I reviewed the Superfund law. I looked at Title 42, Chapter 103, Subchapter 1, Section 9604, that describes Congress's intent for the ATSDR. If you read that paragraph carefully, you'll find that the agency is directed to understand patterns of exposure, to assess human health risks, to conduct tissue testing when necessary. And all of these requirements of Congress, had they occurred on VA case, then I don't believe that we'd be here today. Thank you very much for your attention.
Thank you, Dr. Wargo. Dr. Edwards for 5 minutes.
Yes, and thank you for queuing up the PowerPoint I'll use to support my experiences and observations related to the 2001-2004 D.C. lead and water crisis. The D.C. lead crisis was a historic violation of the public trust by government. Lead in D.C.'s drinking water was very high from 2001 to 2004 due to corrosion of plumbing materials in tens and thousands of homes, apartments, buildings, schools, even the U.S. Congress were impacted. And the levels of lead were very high, some of which exceeded hazardous waste levels, and this danger was hidden from the public for nearly 3 years. When this was revealed in a January 31st, 2004 front page Washington Post article, there was understandably public concern and outrage because lead is perhaps the best known neurotoxin. It affects every vital system in the body. The damage is irreversible, and infants and developing fetus are most vulnerable. The publication of the Washington Post article set in motion 5 different congressional hearings, an investigation led by current U.S. Attorney General Eric Holder, lawsuits, and an investigation by the GAO, all of which were to be derailed by the CDC. In early April 2004, the CDC published what they purported was their assessment of the impacts of the high lead in blood on residents of Washington, D.C. And their conclusion was very clear and unambiguous. They stated that although lead in tap water contributed to a small increase in blood leads, no children were identified with blood lead levels above the 10 microgram per deciliter CDC level of concern, even in the homes with the highest water lead of greater than 300 parts per billion. In other words, according to the CDC, all health impacts were below their level of concern by definition. This publication was little more than a cheap publicity stunt. What the CDC did not reveal was that they had data in their possession that 75% of the consumers whose blood lead they tested had been drinking bottled water for weeks, months, or even a year before their blood lead had been tested, removing all evidence of harm that would have been done. CDC knew about potential forgery in the blood lead data and that thousands of children's blood lead records had gone missing, and they further skewed their data analysis, deleted other critical information that could have put their conclusions into some kind of context. For years, the CDC refused to correct the scientific record, and what's more, they actively blocked any of my attempts to try to figure out what occurred. They did not release data, records, or follow FOIA law. They would not investigate obvious data irregularities and other credible questions I raised. And they did nothing or even encourage the spread of their misguided conclusions, creating untold harm. So when their report hit the press, the news story about the D.C. lead crisis was it was much ado about nothing, and that the real problem was public hysteria because CDC had proved there were no health effects. In Seattle, the CDC study was cited as reason why parents should not be the slightest bit concerned about high lead in Seattle schools' drinking water because of the great work CDC had done in Washington, D.C. And I attended workshops and conferences in Europe, Australia, and Canada where the CDC work was cited as definitive proof that high lead in water did not cause harm to humans. Fed up with this stonewalling by the CDC for over 2 years, I collaborated with Children's National Medical Center, Dr. Dana Best, and a PhD in my research group, and we reevaluated using Children's National Medical Center data the effects of elevated blood lead on young children. And what we discovered was that the high lead in D.C. water caused a 240% increase in lead poisoning for kids less than 30 months of age in neighborhoods that had the highest lead in water, and a greater than 900% increase in lead poisoning for infants less than 15 months of age, many of whom were drinking water made from reconstituted tap water formula. So in conclusion, we determined that high lead in water is a public health concern. And this was known 2,000 years ago, and this is the knowledge that CDC's publicity stunt erased from the public consciousness. I've also concluded that there's a culture of scientific corruption in branches of this important agency, and there's no evidence it has the capability for self-correction. That's it.
Thank you, Dr. Edwards. We will now begin our first round of questions. I now recognize myself for 5 minutes. I am struck by how many people seem not to understand that there is a reason that parents tell their children the story of the little boy who called wolf. There really is a point to the story. It is important to protect your credibility because the day may come when you need to be believed. This seems to be the little agency that cried that there was no public health concern. And there is a time that we need to reassure the public, to tell the public that there is nothing to worry about, to damp down hysteria, to use a word from the Washington Times story 6 years ago. But if the agencies responsible for determining public health do not have credibility, they will not be able to do that credibly. This committee, subcommittee before Dr. Brown's service, studied the possible preparations for a dirty bomb attack a couple of years ago. And one of the things that we needed to be prepared to do in the case of a dirty bomb was to tell the public not just what they had to worry about, but what they didn't have to worry about. That their children were okay, that they could occupy certain areas within our largest cities. And they need to be able to do that credibly. The public needed to believe them, and we need to protect the credibility of our government agencies responsible for determining if there is an environmental health hazard, if they are to play that important role of damping down hysteria when the time comes that there may be panic and there may be hysteria. Dr. Edwards, CDC has, I think just today, issued a new report analysis study in the MMWR, looking again at the 2003, 2004 data. Have you had a chance to look at that?
Yes, I have been sent a copy of that.
And do you have, what is your reaction to it? I'm tempted to say, do you have an opinion satisfactory to yourself? But I'm not a lawyer anymore.
Deception, smoke and mirror gimmicks, perverted science. This is what the CDC embraces. There's nothing in that report that clearly indicates the harm that was done to deceased children, as CDC knows, as it sits there today, occurred. And the new report shows absolutely nothing of relevance other than the sorry state of data that they used for their assessment. And by correcting a single year of data, 2003, and leaving all the other years uncorrected, comes up with a comparison that's completely irrelevant. It took them 8 months of effort to correct the data they relied on for 2003 alone. It would take, therefore, probably another 24 months attempts to get good data for the earlier years, which they need for their comparison.
Dr. Bascetta, the GAO study appears pretty damning of the policies and procedures at ATSDR and NCEH, their procedures for initiating, developing, reviewing, and clearing their public health products. How does ATSDR and CDC begin? Where do they start to fix this problem? They have new leadership at that agency. They will shortly have new at CDC and Dr. Frieden. They will shortly have a new leadership at NCEH and ATSDR. Where do they begin to fix things?
Obviously, the concern today about the MMWR in particular, which has always been viewed as an authoritative source of public health information, is something that they must fix. We made 2 recommendations to ATSDR to develop a risk assessment process to better manage their public health products. And a second recommendation, to revise their existing policies and procedures or to develop new guidance to provide documented direction for various levels of management roles and responsibilities in monitoring. And one of the things we believe very strongly is that this has to happen at the initiation of work and throughout the process, that it's too late to wait for review and clearance, that they need to bring the resources and the expertise to bear early in the process, and that they need to manage their workload so that they can detect any problems early and correct them.
Thank you. My time has expired. I now recognize Dr. Brown for 5 minutes.
Thank you, Mr. Chairman, to the whole panel. The President's Cancer Panel recently released a report on the cancer risk for chemicals and other environmental hazards that was roundly criticized by the American Cancer Society for overestimating these threats. In a critique of the paper, Dr. Michael J. Thune, Vice President Emeritus Epidemiology and Surveillance Research at ACS, stated, quote, "Unfortunately, the perspective of the report is unbalanced by its implications that pollution is the major cause of cancer, and by its dismissal of cancer prevention efforts aimed at the major known causes of cancer, tobacco, obesity, alcohol, infections, hormones, sunlight, as, quote, focused narrowly." Then went on to state, quote, "That report is more provocative when it restates hypotheses as if they are facts. For example, its conclusion that the true burden of environmentally, i.e. pollution, induced cancer has been grossly underestimated does not represent scientific consensus. Rather, it reflects one side of a scientific debate that has continued for almost 30 years, unquote. Before we get into other matters, and since we have such a esteemed panel here today, would you please briefly comment on how the President's panel addressed the risk of environmental cancer versus other causes? The whole panel, who wants to take the first? Pass. Mr. Lester, I see you reaching for the button.
Well, I don't think the report says that the environment is the major source of cancer. What I think it says is that while there are many uncertainties about what we know and don't know about various exposures and various causes, we have a great deal of information about the relationship between these exposures and the toxicity of these chemicals and the susceptibility of the population. And I think the report says that we should take action and we should take steps to reduce exposures to the extent that we can, that we're not doing enough of that. That I think Dr. Wargo mentioned it, is that there seems to be this burden of having to rely on certainty that a chemical is causing a particular health problem, and that if we do that, we're just continuing to allow the population to be exposed and for the varying rates of different kinds of health problems to continue to rise as we're seeing it in the last 5 to 10 years. So I think that the message from that report is really that we should take steps that we can to reduce exposures because there is a lot that we can do along those lines.
Anyone else? Mr. Wargo? Dr. Wargo?
Yeah, I've had a chance to explore that question in a number of different contexts. One was in my experience on VA case, where a very complicated mixture of chemicals was released, and dozens of those compounds are recognized to be carcinogens. Also, I've worked with several National Academy of Science panels that looked at this question with respect to pesticides. And you probably know that there are a number of pesticides, the last I looked, more than 100 that are allowed to be used that are carcinogenic in laboratory studies. Now, there are obvious problems in relying on animal studies alone, but given the long latency period between exposure and the onset of many kinds of tumors, it makes it extremely difficult to prove that a chemical or a mixture induced cancer. Now, I approach this question in a different way, and I think that the President's panel was suggesting a similar route, that it makes good sense to be precautionary and preventative where you can. It makes common sense to figure out where your exposure to carcinogens in the environment are most extreme and to reduce those. In fact, when I think about how my wife and I raised my family, we couldn't prove that any chemicals that were positive in carcinogenicity tests were threatening our children, but it was just prudent to avoid exposure. So I really agree with the panel's recommendations, and I think that much more attention needs to be focused on managing environmental contamination as a way of reducing our burden of exposure to carcinogens.
While I agree more research should be done to better understand environmental causes of cancer, I hope that it will not be a distraction from greater causes. Dr. Graham Colditz of the Washington University School of Medicine, St. Louis, said that the report's overemphasis on environmental toxins could actually cause more harm than good when it comes to the fight against cancer. Quote, maybe up to 4% of cancer in the Western world is caused by contaminants and pollution, and yet we are chasing new unknown causes rather than focusing on acting what we know. Things like this report are making it harder to move the nation to a healthier lifestyle. And I'm very concerned about that as a physician, and my time is up, and I yield back.
It is. Ms. Dowkemper for 5 minutes.
Thank you, Mr. Chairman, and thank the witnesses here today. Mr. Edwards, the main message from the 2004 MMWR, the statements made by federal and city officials was that since blood levels above 10 micrograms per deciliter for children under 6 didn't show elevated numbers, everything was fine. My understanding is that blood levels between 5 and 10 micrograms per deciliter can have serious health and developmental effects and consequences for young children. So do you know why this message wasn't more clearly delivered in the district? And can you just comment on that?
Actually, that message was delivered in the CDC MMWR, that there is no safe level of lead, and that there was a small increase, or there might have been a small increase in blood lead that was observed. But unfortunately, the way it was interpreted by the co-authors of the CDC MMWR who testified to Congress and the D.C. Council and in the press was that because the increase was below the level of concern, that by definition, the health effects were also below the level of concern. So it's unfortunate their subsequent sworn testimony did not look at that issue in more detail, but the reality is, as we showed in our paper, that the blood lead of hundreds, if not thousands, of D.C. children was raised above levels of concern, was raised above levels that constitute lead poisoning.
What was the sampling number on that?
It depends on which part of the study. There was one part of the study which was of 201 residents, supposedly from the worst-case homes, the homes where it wasn't revealed that 75% of the people had been drinking bottled water for weeks to months to a year beforehand. That only had perhaps a dozen children, of whom none were drinking the tap water. There was another study where there were tens of thousands of data collected under their routine surveillance program, and that was subject to a lot of flaws that are detailed in my testimony and in the House report.
Thank you. Dr. Lester, can you tell me, you've been working with ATSDR-related issues for 2 decades now. How have you found ATSDR reacting to your criticism, and what's been your experience over those 2 decades if you've worked with them?
Well, when we first started, they came to us seeking a route to reach the communities that they work with and to try to find a way to solve the concerns and the issues that have been raised. So for a year or so, they were very responsive and conscientious and caring about how they could better work with and involve communities in their work. But as things went on, as time went on, it became clear that they could not continue to develop those relationships. I think a lot of it goes back to the fact that they just don't value what community people know. I think that there are problems with the way they perceive information that people provide to them. And so they did not continue to work with communities or to listen to communities or pay attention to what communities want.
Has there been any recent examples of this in the last 2-3 years?
Yes. I mean, over the years, I think I mentioned in my testimony, they became very slick at changing the language and adopting the language of what people want and appearing to respond as to what people are concerned about. But they actually nothing has changed over the 20 years, in short. I mean, they are just doing many of the same things today that they did 20 years ago, and it's very frustrating to continue to raise these issues with them and then to continue to do what they do.
Ms. Bascetta, without policies and procedures in place, can we have faith in the quality of the work being done by the ATSDR?
It certainly lowers our comfort level without those policies and procedures. The flip side is that having those policies and procedures is necessary but not sufficient to guarantee high product quality, uniform and consistent product quality, because other factors, could come into play. But certainly, having policies and procedures is a necessary first step.
Thank you. My time is just about up. I yield back.
Thank you, Mr. Rothman, for 5 minutes.
Thank you, Mr. Chairman. I'm going to focus most of my questions, if not all of them, on Dr. Wargo with regards to the island of Vieques, Puerto Rico. Firstly, thank you for your work all these years in identifying and highlighting the significant and very disturbing health issues of the people of Vieques. I know, I'm told that in your book you refer approvingly or accept the Puerto Rican health officials' statements that residents of Vieques have a 25% higher infant mortality rate, 30% higher rate of cancer, 95% higher rate of cirrhosis of the liver, and a 381% higher rate of hypertension, as well as a 41% higher rate of diabetes than those on the main island of Puerto Rico, just 8 miles away. And yet, ATSDR saw no connection between those anomalies, if you will, and the dropping of 100 million pounds of explosives and contaminants, including TNT, lead, mercury, PCBs, and other pretty horrific poisons. As you know, based on the prompting of many people, including myself, in May of 2009, ATSDR's Dr. Frumkin was before us and agreed in response to a question of mine to officially, for the first time, as far as I know, reopen the investigation on the health consequences of all those 50-plus years of bombing on the island of Vieques. They say they've put together an independent peer review panel. I submitted 2 names recommended by the mayor of Vieques, 2 scientists. They've just announced, they sent me a letter that I just received, that they're going to put 1 of them on the panel, but that all of the others still have no connection to ATSDR. There is also, and I'm sorry we only have 5 minutes for this, there was a heart disease study done back in 99, I think. So that, of course, would be a peer review and a tissue sample study, would it not? In any event, do you think that, from what you know, and I know you were out there in October at the CDC, do you think that this new panel will give a satisfactory review of and determination about the connection, if any, between these health anomalies of the residents of Vieques and the 52 years of bombing on that island?
No. I think that there are some serious fundamental deficits in the science and the quality of data that is available to the agency. And I also think that in fairness to the agency, if you took their total budget that is allocated toward public health assessments per year, and out of a budget of roughly $75 million per year, probably $10 million of that is allocated to public health assessments. So say you're running ATSDR, and you're responsible for doing health assessments or additional cleanup assessments on hundreds of different Superfund sites, that translates into tens of thousands of dollars only per year. To conduct an epidemiological study, to understand the cardiovascular effects.
Forgive me, Doctor, I have 58 seconds left.
Okay.
Can you provide me, would you be willing to provide me with a list of recommendations on what this new panel needs to do so I can submit it to ATSDR and request/demand that they adopt your recommendations so that you can be confident and I can be confident and the people of Vieques can be confident that this new review will be worth the paper it's written on?
Absolutely. I'd be delighted to do that. And just want to say one other thing about the islanders, 9,300 people that live there and suffered through the 60 years of military activity and bombing. It's incredibly important to think of this group of people as a highly stressed population. When the Navy went in and took their land away, they basically destroyed their jobs. They moved them from their houses. This has been an island under serious social and economic stress for a long time. And we all know that under those conditions you have background medical problems and illnesses that the exposures are sitting on top of. So I think that much more attention by the ATSDR has to be placed on the idea of susceptibility. You know, who are the susceptible people on that island? They're the young. They're the youngest. They are the fetuses in pregnant women. They are also the elderly. These are the population subgroups that I think deserve the greatest degree of attention, and those with other background illnesses that the chemical exposures are piling on top of.
May I have, I'll wait for the second round unless the chairman wishes.
We do have time for a second round.
Very good. Thank you, Chairman.
Because every member is kind of stuck to the 5 minutes. We do have time for a second round. Dr. Edwards, the MMWR is not peer-reviewed, and in fairness, not everything can be peer-reviewed. I think even the critics who suggested there should be further peer reviews, that there is a sampling at least, not that everything be peer-reviewed. But you certainly qualify as a peer and have looked more closely at the MMWR analysis than just about anybody. And you were also very critical of today's publication. Have you compared the fundamental findings of that 2004 MMWR to the publication today, and particularly the reliance on the cross-sectional study that found no correlation between the highest, the elevated water lead levels and blood lead levels?
Well, the thing I most remember about the new publication, and I've just seen it, this morning, is that they're now claiming that their conclusion all along was that children living in homes with lead pipes had much higher blood lead than children living in homes without lead pipe, and implying that the public's conclusions were a result of misreading the earlier publication. And that's absolutely false. If you look at their quote, where they talk about that in the new publication, it leaves out a sentence before it in the original MMWR that specifically says that the children living in the homes with lead pipes have high blood lead because of lead paint and other sources, not water. So they left that out. They're trying to rewrite history in the most blatant way I can imagine.
Okay, and with respect, I know you've already touched on this, well, more than touched on it. You discussed it at some length, but again, what flaws did you see in the cross-sectional study from the 2004?
You mean the study of the
comparison of water level, water lead level, and blood lead level?
In the 300 ppb study?
Right.
Oh, well, the first and foremost, not mentioning the water filter use, even though the authors discussed that they should put that in the publication, and they purposefully decided not to mention it. The fact that there was this sampling gap and that those residents were not the worst case in the city, but in fact was the group of residents in the city least likely to show harm from the high lead in water. So it's completely mischaracterizing what they did.
Okay. Ms. Bascetta, the GAO report did emphasize, I just touched on peer review, Do you know how often ATSDR now does conduct peer review, and how often do you think it should conduct peer review?
For their largest category of studies, out of 282, they only chose to do peer review twice. All of their health studies, but that's a very small proportion of their work, are peer reviewed. And as for what our suggestion would be, it's hard to answer that question without knowing more about the specific circumstances in which the peer review might be warranted. But they do have criteria for where they think that a higher level of review is warranted, either from internal peer review or externally. And I would suggest that they take a look at those criteria and try to figure out in what percentage of cases they need to apply that more consistently across all their products.
Okay. Dr. Edwards, back to the DC water. There was one child who did have elevated lead levels, and they decided to exclude him from the study because they thought he'd not been living there long enough. Do you have a sense of how long it takes exposure to affect the blood lead level, and was it scientifically valid to exclude that child? And do you have any information that they excluded children from the study who had not lived there that long, but did not live in that house for very long, but did not have high blood level either? Lead level.
Yes, at the levels of lead in water, the highest lead in water levels in D.C. at that time, 24,000, 48,000 parts per billion lead in water. These are 9 times hazardous waste levels of lead in the water. Drinking a single glass of water at that level could elevate your blood lead over CDC's level of concern and cause lead poisoning. There is no doubt about it. So drinking a single glass of DC tap water at that time, if you were one of the unlucky ones to get that very, very high dose of lead, that's all it would have required, 1 glass of water.
So if a child had been living in a house for a couple of months, they should not have been excluded from the study. And that seems a fairly obvious.
That was part of my
conclusion, yes.
allegations to CDC. Why is it you're deleting from your study your known evidence about children that did have high blood lead? And the reason is because they could not allow it to be perceived that even a single child had been harmed, not one.
I know that I've praised every member of the committee for sticking to the 5 minutes, and now I will exceed it slightly myself. Dr. Edwards, none of us particularly like criticism, but you've been very critical in CEH and ATSDR's work in this area, CDC's work in this area. How have they taken your criticism? Have they regarded it as helpful and constructive, or perhaps less welcoming of it?
Well, they've been very welcoming, to say the least. But worse than what is constituted the scientific misconduct, possible scientific misconduct in the CDC MMWR, is that they refused for years to correct the public record. They saw this being misused not only in D.C., but all around the country and around the world, and they refused to correct the record.
Thank you. Dr. Brown is now recognized for 6 minutes and 25 seconds.
Thank you, Mr. Chairman. After hearing y'all's testimony, I think that the American public should be very concerned about any product that ATSDR puts out. Under the Superfund amendments to the and Reauthorization Act, it exempted ATSDR from peer review. Can you tell me why we should not repeal that exemption? I see no reason that they should be exempted from peer review, just as Dr. Edwards was just talking about these exemptions, exempting folks from the study and how the study was done. Even I'm a medical doctor of practicing physician, and some members of this committee who are more true research scientists don't call me scientific, but I'm an applied scientist, and I'm just appalled at the products that ATSDR is putting out, frankly. Why shouldn't we is there any reason to not remove this exemption on peer review? We'll start with Dr. Edwards and then Dr. Wargo.
Well, I can't really speak authoritatively to that issue. What I can say in the case of the CDC MMWR, that the lead author from the CDC gave all her co-authors less than 3 hours to review the publication and determine whether they wanted to be co-author or not. So not only is it not being peer reviewed in some cases, the co-authors are not even being given chance to give input to the publication, and when they gave input, in many instances, it was ignored. And I also showed that CDC violated its own clearance policies time and time again related to this publication. So it'd be helpful if they started following their own rules to guard against release of misguided information before we started talking about additional rules, which might very well be useful.
So your answer is you think that we should remove the exemption for peer review there? Yes,
I don't feel I can answer the question. Yeah, so
Okay. Dr. Wargo?
I couldn't agree with you more. I think that that exemption has created very serious problems of credibility for the agency. And I've also participated in panels working with the Environmental Protection Agency on their science advisory panel and their science review board. And I know that those reviews can be conducted in an open, a transparent, and a highly scientific and highly critical forum efficiently. And that's the key. You don't want to have the public health assessments held up for 6 months or a year to go through a peer review process. But if you have a standing group of experts in an area that know the literature, that are recognized to be the best in their field, this can happen quite efficiently. I see no reason to maintain that exemption.
Dr. Wargo, do you think this can be done in an expeditious manner, or is there, as Dr. Edwards was talking about, that the co-authors offered just hours, but that seems to be a bit hasty to me. But can we do this expeditiously and still have peer review?
I believe you can. I believe you can, and I think that having, say, standing panels of experts that are on call to conduct peer reviews in ways that would not prolong the agency's deliberations before they release a document, especially when you have a community that might be being exposed and at risk, you want that opportunity to intervene quickly. So I see it happen in the scientific community all the time.
Thank you very much. I'm not going to use my whole 6 minutes and 28 seconds, so I yield back.
I think Dr. Brown is just trying to make the chairman look bad. Mr. Rothman for 5 minutes.
That would be impossible, Mr. Chairman. Dr. Wargo, we received, or my office received, after a request, some written assurances from ATSDR that they were aware of the limitations of health care access on Vieques, as they were aware of the many health problems of the people of Vieques. And they said that, paraphrasing, while they could not provide the care themselves, they have committed to work with public health and health care partners to seek improvement in access to health care. Do you know of any evidence of their activities in that regard?
No, I do not. And I fully agree that there are problems with providing medical care to the islanders. To get on and off that island commonly takes either a plane ticket, which is expensive to get to San Juan, or most of the islanders would get to the main island by taking a 2-hour ferry. So if you have an emergency situation, it's just not sustainable.
And there's certainly not. I don't believe there's a hospital on the island. I'm not even sure. Is there a clinic on the island?
There is a clinic on the island.
Okay.
But that community needs its own state-of-the-art hospital.
Right. Given one would imagine the moral responsibility of the people of the United States who were the beneficiaries of the 50-plus years of research and the bombing and use of our weaponry to protect our country, one one would argue, I argue, that we have a moral responsibility to take care of the residents of that island, the 10,000 or less, who suffered the consequences of, in essence, protecting us by allowing us to test our munitions. There is this Vieques was designated a federal Superfund site. Am I correct, Dr. Wargo?
Yes, that's correct.
Okay. Is it ATSDR's role to say in its report that even if they don't find a connection between the poisons dropped or contaminants dropped on their island over 52 years and these health status anomalies, if that's the right way to describe these higher rates of diseases and bad physical conditions, even if they don't find a connection, is it their job to recommend that these people be taken care of, or is that by the U.S. government in some way, or must that come from someplace else?
Well, I read the provision in the statute that I cited earlier, and it's very clear in that provision that they do have a responsibility, that they have a responsibility to suggest opportunities for exposure reduction, and if they understand that there are adverse health outcomes, they have an obligation as well to consider what might be done in order to treat illnesses.
Is that only if the illnesses were related to exposure?
Well, that's not clear in the code, and it strikes me that again, if you've got a population that is stressed, that has a high background incidence of the illnesses that you just reviewed, and they are being exposed to chemicals that are well known.
But they'd have to come to that. They'd have to make that finding. They'd have to make that connection.
Well, they would, but you know, if knowing what I know about that island, you'd be pretty hard-pressed to reach a conclusion that those islanders were not exposed to those chemicals.
I agree with you, and ATSDR, in a recent letter to us, said that they believe that further investigation is warranted and that they will support Puerto Rican health officials and public health agencies to pursue that further investigation. Again, I would ask kindly and respectfully if you could provide my office as soon as possible with your list of recommendations that we will pass on immediately to ATSDR so that we can get a fair and medically credible, scientifically credible conclusion or examination completed as soon as possible by ATSDR.
May I respond just very briefly?
Yes.
It strikes me that the agency should be thinking about the problem in a very different way. They should be thinking about it as an opportunity to understand how to reduce exposures, not 6 months down the road, not 5 years down the road, but tomorrow. And there are opportunities to do that.
To reduce exposures on Vieques or in other places?
On Vieques. But, I mean, the same principle, I think, should apply to all Superfund sites and all communities that live adjacent to them.
Would you include that in your list of recommendations?
Absolutely.
I thank the chairman.
Thank you, and the chair thanks Mr. Rothman for exceeding his time.
You're welcome.
And we will include in the record Dr. Wargo's response. We will now take a short break between panels. Thank all of you for appearing today, and we'll be back in a minute with Dr. Ikeda.
Yeah, I knew that.
Thank you very much.
You covered a lot.
Can we get Dr. Ikeda in place? It is now my pleasure to introduce our second panel, which consists of one witness, Dr. Robin Ikeda. Dr. Ikeda serves as the Deputy Director for the Office of Noncommunicable Diseases, Injury, and Environmental Health, and is the Acting Director for the National Center for Injury Prevention and Control at CDC. She has an undergraduate degree from Stanford, an MD from Cornell, and an MPH, Master of Public Health degree from Emory. As our witness should know from having been here earlier, you will have 5 minutes for your spoken testimony. Your written testimony will be included in its entirety in the record for the hearing. When you have completed your spoken testimony, we will begin with questions, and each member will have 5 minutes, and likely we'll only have one panel, one round. I'm sure you're disappointed. It is the practice of the subcommittee to take testimony under oath, as you saw earlier. Do you have any objection to taking an oath? The witness spoke the word no. You also have the right to be represented by counsel. Do you have personal counsel here? Okay. If you will now please stand and raise your right hand. Do you swear to tell the truth and nothing but the truth? Okay. Dr. Ikeda has taken the oath. Dr. Ikeda, you are now recognized for 5 minutes for your spoken testimony.
Good morning, Chairman Miller, Ranking Member Brown, and other distinguished members of the subcommittee. On behalf of Dr. Thomas Frieden, Director of the Centers for Disease Control and Prevention, CDC, and Administrator of the Agency for Toxic Substances and Disease Registry, ATSDR, I would like to thank you for the opportunity to present this testimony. I'm Captain Robin Ikeda, a physician and a member of the United States Public Health Service Commission Corps. Since February 2010, I've served as the CDC Deputy Director for Non-Communicable Disease. In this position, I provide guidance and leadership to the 4 non-communicable disease centers at CDC, including the National Center for Environmental Health and ATSDR. I've worked at CDC for nearly 2 decades and have served as Associate Director for Science at both the Epidemiology Program Office and at the National Center for Injury Prevention and Control. Today, I will focus on several areas of interest to the subcommittee: improvements underway within NCEH ATSDR, the national conversation, CDC's work on elevated lead in Washington, D.C. drinking water, and the fresh look that ATSDR is taking on the island of Vieques in the Commonwealth of Puerto Rico. CDC ATSDR's senior leadership understands the need to improve ATSDR's ability to address concerns of communities related to potential exposures to hazardous substances. A team from the Government Accountability Office, GAO, recently reviewed ATSDR's processes related to preparation and review of scientific manuscripts. We appreciate the GAO recommendations to improve ATSDR's procedures. In particular, ATSDR is working to strengthen both our priority setting and project management to make them more explicit and consistent across the agency. Staff roles and responsibilities from project inception to publication of findings must also be clearly defined and understood. On a larger scale, NCEH ATSDR, along with many others, launched the national conversation in June 2009. Individuals from dozens of organizations are represented on the National Conversation's 6 work groups. This 2-year project will identify strategies to better protect the public from harmful chemical exposures. The National Conversation is currently at the midpoint in the process. Recommendations from the project's Leadership Council are expected this winter. Moving to more specific areas, I'll touch on our efforts to address lead in the District of Columbia drinking water. As you've heard, between 2000 and 2003, the District of Columbia detected a very high lead concentration in its drinking water. Available surveillance data were analyzed, and in April 2004, CDC reported that lead in tap water contributed to a small increase in blood lead levels in D.C. among those living in homes with lead service lines. Several concerns have been raised about this report. A critical issue has been the missing blood lead data from 2003 and whether this compromised our analysis. Given these concerns, we took steps to obtain the data that we should have had for the 2003 analysis. We conducted a complete reanalysis and invited outside experts to review our work. Today, I can report to you that our more comprehensive analysis did not fundamentally change our findings from 2004. These results were released on our website yesterday and will be announced in CDC's MMWR, that's the Morbidity and Mortality Report, today. My final topic is ATSDR's work on the island of Vieques. Between 1999 and 2006, ATSDR evaluated the extent of exposures to hazardous substances and potential health effects. As part of this work, ATSDR used available data collected from a variety of sources. In general, these reports found that residents of Vieques had likely been exposed to contaminants. However, the levels of exposure were sufficiently low that the available scientific methods at that time could not establish a link to negative health effects. In 2009, ATSDR pledged to take a fresh look at the island of Vieques. This has involved both a thorough review of its previous work on the island and any new scientific data. In August 2009, ATSDR leadership and staff visited the island and during November convened a face-to-face consultation with independent scientists, including individuals from Puerto Rico and from academic institutions on the mainland. ATSDR is in the final stages of completing a draft report. This document will be externally peer-reviewed and then shared with this committee and the public for comment. NCEH ATSDR works to address environmental public health concerns, including those raised by communities. Although we have assembled a strong record of accomplishment, we continually seek to strengthen our ability to prevent harmful exposures and to protect the public. I am committed to applying my 19 years of experience at CDC, particularly my service as Associate Director for Science, to guide this ongoing improvement in our work. I look forward to working with the new director of NCEH ATSDR and Dr. Frieden to protect the public from dangerous environmental exposures. Thank you, Mr. Chairman and members of the subcommittee, for this opportunity to testify before you today.
Thank you, Dr. Ikeda. We'll now have a round of questioning, and the chair recognizes himself for 5 minutes. Dr. Ikeda, there's been some assertion that the MMWR from 2004 was misinterpreted, was widely misinterpreted as saying that there really was not a public health concern, that was not the intent, it shouldn't have been read that way. But it does appear to have been widely reported in the press that was the takeaway, the lesson, and it appears that was, in fact, from the documents that you all have provided or that we have obtained, that seems to be the intended message. That there was a talking points for Dr. Broun. Main message: there is no indication that DC residents have blood lead levels above the CDC levels of concern of 10 micrograms per deciliter for children 6 months to 15 years old and 25 micrograms per deciliter for adults as a result of lead in the water. There was an email exchange between Dr. Falk, who's in the head of ATSDR in CEH, and Dr. Broun, referring to the MMWR. Dr. Falk said, have you had many calls? Ray this, how's it going? She wrote back, today has been the first day in over a month that there wasn't a story or on lead in water in the Washington Post, and also the first that I haven't been interviewed by at least one news outlet. I guess that means it worked. What steps should ATSDR and NCEH and CDC take in the future, or do you think it was incumbent upon those agencies to correct a misimpression? Did they do as they should have, and how do you go forward from here?
One of the reasons that we published the MMWR today, this is the notice to readers that points people in the direction of the reanalysis, was to correct the record, was to let people know that we understood that our comments in the MMWR from 2004 were ambiguous and open to interpretation. So we wanted to make sure that people understood the principal message that we intended from 2004. Certainly we know that no lead level is safe, and that we're very concerned about addressing and preventing, controlling, eliminating lead exposure from any source. In terms of, I think, the larger question that you were asking about how ATSDR can move forward from here, we've heard a number of comments today about concerns raised about scientific quality at ATSDR, procedural issues at ATSDR, and we're working to correct those. There are a number of improvements that are in place already and others that we're contemplating and thinking about in terms of moving forward. Dr. Frieden is very committed to ensuring the highest quality of science at ATSDR. I know that you and he have had conversations about that, and it's my responsibility as Deputy Director to make sure that that commitment is carried through. So I look forward to working with him and our new director to ensure that we improve the overall processes, procedures, and scientific quality at ATSDR.
With respect to the DC lead issue and the 2004 MMWR, what is published today does not specifically retract or correct the weaknesses of the cross-sectional study, which was the most single-sided part of the study. You heard Dr. Edwards' testimony today that it had a very fundamental flaw that was hard to imagine was not intentional, that it left the impression that children drinking the water did not have elevated blood lead levels. That's not easy to say. When in fact they weren't, the vast majority of the children, perhaps all the children, weren't drinking the water at all. Have you corrected that part of the record?
And again, we hope that our statement today and the notice to reader in the MMWR will indicate to folks that we realize that statements in that original MMWR were ambiguous and open to interpretation. The cross-sectional study has not been repeated, so I can't speak to whether there's any ability to redo that study or not. Certainly that study had limitations as well. We heard already today about the limited numbers, the possibility of other confounding factors influencing the results, et cetera.
My time has expired. Dr. Brown for 5 minutes.
Thank you, Mr. Chairman. Dr. Ikeda, in the case of formaldehyde levels in FEMA trailers, EPA conducted sampling after limited consultation with ATSDR. That sampling was deemed to be insufficient to characterize long-term exposure. In the case of DC lead water, the agency received insufficient data from the DC Health Department of Health that was also counterintuitive. How does the agency now ensure that it receives appropriate samples and the data to adequately characterize exposure and risk?
In addition to the improvements that I mentioned earlier that are specific to ATSDR, there's a number of organizational CDC improvements that are also ongoing. Certainly our efforts to build state and local capacity and to strengthen our relationships and how we work with state and local health departments and labs would assist in this effort. You may know that CDC underwent an organizational improvement over the past several months, and we now have a new Office for State, Local, Tribal, Territorial Support, which is designed to help us strengthen those relationships and make sure that we provide the appropriate levels of technical assistance to states and locals and laboratories, and also to address some of the accountability issues that have been a problem in the past.
Okay, Doctor, what does ATSDR have if sampling data is limited for a particular review? How challenging is this in terms of communicating results, and how do you propose ATSDR address this issue?
I think there's a couple different things in that question. Often in science we have limited information. And, you know, we joke in science that more studies are needed because that's always true. We always feel like we need more information. We never have perfect understanding. And science is very dynamic, that it's always changing. There's always new information. So there's that part of it. We can always try and get more information, more samples. But the other piece of it is the communication piece. So how do we, when we have limited information, how do we share findings and recommendations? How do we even craft findings and recommendations when the data are limited? And that really is an art, and we have to make sure that our communication messages are clear and that we document and let folks know that it's limited in whatever way.
Doctor, is caveating the limitations in the report your only option that you have on sampling data?
I'm sorry, I'm not sure.
Is caveating the limitations in the report of the sampling data, is that your only option of trying to make sure that the particular review is appropriate?
I'm sorry, and if I'm not answering the question, forgive me. I think we would try and make efforts to achieve the appropriate samples or the full sample size that we would want. I guess I'm assuming that we're talking in a world where these samples don't exist, that we don't have more of them. But there are other communication venues that we could use to make sure that people understand that, you know, we're making these recommendations based on limited information.
I want to go back to the previous panel where we were talking about the exemption for peer review and the as well as the not only the methodology but the results of the reviews. Would CDC welcome a peer review process that is mandated and not exempted as it is today, and would you welcome a review of the findings beyond the methodology, just what the conclusions would be from that peer review, as well as a review of the findings from the data samples that you get?
Peer review is a pillar of good science, and certainly we welcome peer review in many different forms at CDC. As someone who oversaw peer review for other centers at CDC, I recognize the value of transparent peer review. I think you heard some of the concerns raised about peer review here, that, again, we need to balance the rigor of peer review and the time that it takes to conduct good peer review with the need to get information out quickly, particularly in emergent settings. So, yes, in general, peer review is you know, we support peer review wholeheartedly. I think it's just trying to balance when it's appropriate, whether it's for all documents, and the timeliness with which we can then move out with recommendations.
Thank you, Doctor. If I may take my extra minute, Mr. Chairman, here I've got one more quick question. As a physician, and know that you're a physician also, we look at data, we look at results, and what I was taught in medical school 5 years later was taught in medical school as being absolute fact. 5 years later, we were being taught exactly the opposite. When you have this expeditious process, do y'all have any kind of process in place or mechanism in place to come back and re-review what was done in such a hurried-up manner so that the appropriate findings, if they were indeed found in the original review, are still valid, or if there is another set of conclusions that may be counter to the original findings? Is there a process, or is there not one to go back and do that?
I think it depends on the type of product. Certainly things that CDC puts out that are listed as interim recommendations, for example, in an H1N1 type situation where, again, they're trying to get recommendations out in an expeditious way, and yet they realize that the science on which it's based may not be complete. So for things like that, it's clearly labeled, you know, this is interim, with the understanding that this is preliminary based on the best information that we have now, but we know we need to get it out quickly. For those types of documents, there is a process because it was labeled interim to begin with, and so there's a process by which it's reviewed if and when other additional data become available. For other documents, I think it's less clear. It's part of the general scientific process, as you were describing, where information is always changing, new information is always at hand, and that findings and conclusions and results and recommendations may change over time.
Thank you, Doctor, and I appreciate your letting me have a few extra minutes, Mr. Chairman. Thank you. I yield back.
And the chair thanks Dr. Brown for his exceeding his time, although he didn't need to exceed it quite that much. The chair now recognizes Mr. Rothman.
I thank the chairman, and let me, I was remiss in not thanking you earlier, Mr. Chairman, for holding this hearing. It's extremely important. Dr. Ikeda, thank you for being here. I got a lot of questions. I'm going to try to ask them quickly, and I hope you can give me as concise answers as possible. Do you know, I got a letter from Dr. Frieden saying that he had, pursuant to my request and the Mayor of Vieques' request, decided to accept at least one of the two scientists that the Mayor of Vieques had requested be a part of the study, although he did say that they've already established or identified their peer review panel, and this scientist would be an adjunct reviewer of the report whose comments would be carefully considered. Do you know the name of the scientist that was chosen? Okay, if you can get that to us as soon as possible, that'd be great. You said in your testimony that the date of the draft was expected. I'm paraphrasing. Soon, reasonably shortly. Do you have some kind of a better date estimate than that?
I don't have a specific date estimate. I do know that the draft report is being prepared now to be delivered to the peer reviewers. So the panel of 7 peer reviewers will then review, provide their comments, come back to CDC to incorporate those comments, consider those comments. So those are the steps that will be taking place.
Thank you. I mentioned earlier, I don't know if you were here, that I thought that the United States had a moral obligation to the people of Vieques to take care of them because it seems obvious that there is a connection between the dropping of 100 or several hundred million pounds of contaminants on that island over 52 years has caused health problems to these people. And the people are suffering as a result. Clear that if one is to believe the findings of the Puerto Rican health authorities, there are unusually high levels of infant mortality, cancer, cirrhosis of the liver, hypertension, and diabetes, amongst other things going on. I sit on another committee, in addition to this one, called the Appropriations Committee, and I'm on the Defense, amongst others, Subcommittee of Appropriations. Could you make sure, or do I need to put this in writing, that we get a recommendation whether there's a causal connection acknowledged in the final report between these high rates of illnesses on the island in the people of Vieques and the dropping of these, and the creation of this federal Superfund site by the dropping of these poisons on the island for 52 years, whether or not they make a connection. Could you tell us how much it would cost to establish a sufficient medical facility on that island to take care of these people, and how much it would cost? Let me just finish. And perhaps wearing that other hat of mine, I can then try to get the resources to establish that appropriate facility to take care of these people.
I don't know how much it would cost, but I can certainly consult with colleagues, and we can do our best to provide an estimate. But
Can we make it a part of the report, though?
From the consultation in November, there was clear discussion about CDC's role in terms of assisting Puerto Rico health officials to make sure that clinical care was received by folks. And again,
In light of that, I have 27 seconds, sorry. In light of that acknowledgement by CDC that you wanted to help the Puerto Rican healthcare officials, I'm requesting that you put a dollar amount on what help is necessary to completely address the healthcare issues that are being suffered by the people of Vieques.
thank you for the suggestion.
Thank you.
Thank you. We have been joined by the delegate from the District of Columbia, Eleanor Holmes Norton. I ask unanimous consent that Ms. Norton join the panel without objection. And the chair now recognizes Ms. Norton for 5 minutes.
Chairman Miller, I certainly can't thank you enough, and I thank you and the ranking member for allowing me to question this witness and to join the panel. But I want to thank you, Mr. Chairman, especially for the enormously important follow-through you have done here with this investigation. This matter was a matter of national concerns. What you do here, you do not only for the residents of the District of Columbia, but for all of those who were aroused by the notion that in, of all places, the nation's capital, there was lead in the water. Some of these families, of course, came to see me in the Government Oversight and Reform Committee, which has jurisdiction over District of Columbia matters. There were a number of hearings in which we also were told that there was nothing to fear but fear itself. Those hearings were in 2004. There was panic, particularly among young women with children, and some of those who came to see me were pregnant. We're told not to worry. Therefore, Dr. Ikeda, I've got to be concerned now. That was then, this is now. In light of what we know now about what CDC reported to them, my concern is with the families that have now been identified. We know who has experienced lead in the water of 5 to 10 milligrams above what it should have been. We know that those who rushed to change their pipes, changed only part of the pipes, now have worse conditions involving lead. What can CDC do now for these now identified families? What specifically can you do? Do you intend to notify them? Do you intend to be in touch with them and to examine them and their children for the health effects of this misinformation?
The CDC works with local and state health department lead programs, who in turn then work directly with families who have been exposed or who have been discovered to have high levels of lead. And there are the programs that are in place include contact with the individuals, counseling.
Dr. Ikeda, I'm going to have to ask you very specifically. I'm not asking you about the CDC's programs. I'm well aware of them. I'm asking you whether in preparing your testimony, now that you know what has occurred, what specific initiative you believe CDC should take in this situation now with respect to whatever it is you can do and what services you can provide. Not what services are generally available. What is it that CDC can do? What will you be asking CDC staff to do, if anything?
And I'm sorry if I'm misunderstanding your question. I would say that we work through the lead prevention programs to make sure that children and families are appropriately
You've been in
taken
touch
care of.
with the District of Columbia
Yes, our lead programming folks work
regarding
direct-
this new
direct-
information.
I don't know about regarding the new information. I do know that we posted and shared letter to dear colleague type letter, letting them know that this information had been released on our website yesterday and that the MMWR notice to readers was being published today. So
Do you
that-
intend to meet with the mayor or with health officials in the District of Columbia?
I don't know.
You don't know whether you intend to meet or have CDC staff meet with health officials or the mayor of the District of Columbia. You don't know that.
I'll
You can't
certainly-
testify that you will do that.
No, I was responding to the question that I don't know, but I can certainly take the suggestion back to our.
I wish you would
to our
take the
staff.
suggestion, it seems to me all but obvious, that CDC be in touch immediately with health officials in the District of Columbia to offer specific services to them and to the identified families. I would very much appreciate that.
I will.
Thank you, Dr. Ikeda, and thank you very much, Mr. Chairman.
Thank you. We are at the end of our time. The President of Mexico is speaking to a joint session in just a short while. There has certainly been a problem with the paralysis, intentional paralysis by analysis on environmental issues. This subcommittee, I have been very critical in the last Congress of the last administration for the work at OIRA in insisting upon studies of studies of studies before finding anything to present a public health risk. Formaldehyde being perhaps the best example.
May I have 20 seconds, Mr. Chairman?
Mr. Rothman is recognized for 20 seconds.
I want to just clarify one thing, Dr. Ikeda. I believe that there's a connection between the bad health situation of the people of Vieques and what we did to the island, the United States did for 52 years. And I believe that the proper study should reveal that. So I don't want to, my comments that there should be a health clinic, regardless of the findings, to be misinterpreted otherwise. I believe there is a connection. I believe a fair and scientifically valid study will prove that, and I hope that with the new procedures it will. Thank you, Mr. Chairman.
Thank you. Formaldehyde, there were studies upon studies upon studies, studies of studies. All of that seemed to be urged by the administration, by the formaldehyde industry, and by allies in Congress. Our former colleague, Marc was best known in Congress for two positions. One was that sex was bad for you, and the other was that formaldehyde was good for you. He apparently changed his position on sex, but maybe not on formaldehyde. We don't want to get to that point. We don't want to have paralysis by analysis, but we do want to have sound science that has credibility, that does reach a conclusion, but one that can be taken seriously. I do hope that the new, I have, as you've pointed out, spoken to Dr. Frieden, and I trust that we will again. I hope that there is an effort to make this an agency that the professionals who work there can be proud of the work they do, and that the nation can rely upon the work they do. We need that. So I want to thank all of our witnesses for testifying. The record will remain open for a couple of weeks, for 2 weeks, for any additional statements from members. I know that Dr. Wargo was going to provide a response to a question from Mr. Rothman. And with that, the witnesses are now excused and the hearing is adjourned.
Good job.